Starting with the topic for the evening today. The first topic is the transfacetal radiofrequency denervation for lumbar facet arthropathy. So basically, it is a modification of a new technique which I'm going to describe, and this has been done by me. I started doing this procedure in 2023. And let us start with the background of the technique. Lumbar facet arthropathy is an important cause of chronic low back ache, giving rise to around 15 to 45% of chronic low back aches are attributable to lumbar facet arthropathy. Amongst different etiologies, adjacent segment degeneration subsequent to spinal fusion is an important cause of lumbar facet arthropathy. RF lesioning is an effective treatment for lumbar facet arthropathy. However, in presence of spinal hardware, many number of times we find that the visualization of the landmarks becomes difficult, and also because of instrumentation, the local anatomy gets distorted. So let us start our discussions with these backgrounds in our mind. So the first case report was that of a 56-year-old male with 88 kg and 168 centimeter with a BMI of 31.2. And the patient presented with me with a unilateral left-sided localized non-radiating pain in the low back and with a NRS of 9 upon 10. There was a history of having performed T-leaf procedure at L4, L5 in November 2022. The patient had good pain relief lasting for around 3 months after the surgery, after which he started to have recurrence. On detailed questioning, what I found was that the low back ache was of a different pattern. What he revealed to me was that the prior to surgery, he was having a dull and diffuse sort of low back ache with a NRS of around 7 to 10. He was having difficulty in prolonged sitting, standing, and bending forwards. That was his main complaint out there. And at the same time, he also had radiation to right lower limb involving the feet, calf, and the heel. On examining the pre-op MRI, there was a degenerative disease at L4, L5 with herniation. So as you can see in the image, he had a degenerative disc disease with herniation, and it was more central herniation with a slight propensity to go towards the right lateral viscus. So and the current pain pattern was quite very different from what he had before. It was unilateral, left-sided, localized to left paramedian region, and the intensity was much more than before. The NRS was around 9 to 10. The patient was having difficulty in turning around on bed. The pain used to aggravate early morning, and slowly it used to get rid. What he described to me was that mornings are the worst period of his time. Then the patient was having difficulty in sitting, in standing from sitting position. Like when he used to get up from his toilet seat, the patient used to have a very hard time doing that. And the patient had difficulty on prolonged standing. So what he ultimately had to tell me was कि डॉक्टर साहब मैं तो बिना सर्जरी कराए बेहतर था पहले सर्जरी कराने के बाद तो मेरी हालत और खराब हो गई सो with that in mind, I started doing the examination, which revealed that the Revel sign was positive. The patient was having localized tenderness corresponding to the left lower lumbar facial column,
हाँ,
and that was below the lesion,
मला
below
सारा
the
काम
level of the incision.
दिया नहीं है वो
So, and on deep palpation, it corresponded on fluoroscope. So what I did was I took the patient to the OT and under fluoroscopy did a deep palpation and the pain that was reproduced was over the left L5S1 facet joint. So there was a provisional diagnosis of left L5S1 facet arthropathy made. And because of the history of spinal instrumentation, we made a etiological diagnosis of adjacent segment degeneration. Confirmation of the diagnosis was done by injecting into the L5S1 facet joint with bupivacaine, which produced near complete pain relief. So the next plan was to do a radio frequency denervation of the left L5S1 facet joint. But the problem over here was because the spinal instrumentation, there was the mammilla accessory groove was just not visible. So, but the good thing was I had a very prominent L5S1 facet joint visible. So as a modification, what I did was I took three 18 gauge 1010 cannulas, which I put one in the upper pole, one in the lower pole, and the one approximately midway between them. Having placed the cannulas, I did a sensory stimulation, one first with 50 hertz current to have a reproduction of symptom at zero point 0.5 milliampere. And then I also did 2 hertz current stimulation at 2 volts. And when there was no stimulus of the nerves, I did a 70-degree centigrade lesioning for 90 seconds, just for a single cycle through all the three electrodes, all the three cannulas. After having observed the patient for around 2 hours post-procedure, the patient still was reporting excellent pain relief, after which he was discharged. So as a routine protocol, my protocol is to have a mandatory physical review at 1 month post-procedure. And then the patient can do virtual consults at 6 months and 12 months and SOS thereafter. So the NRS on all the three occasions were 1 and 1 at first month and 6 months. And at 12 months, he had the NRS reported as 2. And the pain relief was satisfactory on all the three occasions as per him. So as a second, because, first, a single procedure can always be serendipity. So what I did was I, after 2-3 months, when another patient came up with lumbar facet arthropathy, what I did in him was the same transversal technique, but with a slight modification. That this time I used 22 gauge 1010 RF needles, and I put one of them in the upper pole and the second one in the lower pole without without putting in the third needle. And the radiofrequency treatment was done in the with the same temperature, that is 70 degrees centigrade, for 90 seconds through both the needles, one at the upper pole and one in the lower pole. And again, after having done the follow-up, it was the NRS was 1, 3, and 3 at first month, 6 month, and 12 months. And even this patient reported the pain relief as satisfactory. So coming on to the discussion part of this technique, lumbar facet arthropathy, as I had told you before, contributes to around 15 to 45% of chronic low back aches. And radiofrequency treatment is considered as the standard interventional management for minimally invasive procedure. What we usually do is we try to insinuate our needles in the mammulo-accessory groove, as you can see here. So this is the conventional technique that we usually follow. But in this case, because of the presence of hardware, the mammulo-accessory groove was not visible. Now, adjacent segment degeneration, because many people are quite unaware about this entity. So adjacent segment degeneration, or using short form as ASD, it is referred to as the degenerative changes in the unfused segment adjacent to the fused segments after lumbar fusion. So it can happen in any of the, like it can happen in the cervical, it can happen in the thoracic as well as in the lumbar area. And it can lead to so-called recurrence of symptoms. Yuan et al. Have reasoned that the ASD happens because of the biomechanical changes in the adjacent spine segments, and the biomechanical changes can result with in disc degeneration or spondylosis even involving the pars and the facet joints. The incidence of adjacent segment degeneration is around 5 to 49%, as reported in different literature at different times. Etiologies, most common etiologies suggested are age, hypertension, presence of diabetes mellitus, smoking, and the number of levels fused. So the more number of levels that you fuse, more there are the chances of getting in adjacent segment degeneration. Now, there are very good few literature articles in ASD. So one of these, I think this must be the maximum, I mean, the one with maximum. Let me just reduce the screen here. So they did this study. It was a retrospective study, and it involved approximately around 1,200 patients, and they reported an incidence of around 5.2% in their study. The time of onset of adjacent segment degeneration was reported as to average between 20 to 123 months. Here, if you would notice that the time of onset in my case, uh, the first case was around 4 months. Uh, Another thing that they reported was there is more propensity for the ASD to occur more cranial to the surgery. Right. So if it is L4, L5, the patients will have, the levels involving above L4. Whereas in my case, what I found was it was caudal rather than cranial. And the risk factors that they described was BMI of around, 25 to 29. In my case, the patient had BMI of 31.2. Right. And the another risk factor that they found in their study was pre-op adjacent disc degeneration. In the other uh, etiologies that were described elsewhere in the literature, like age, hypertension, diabetes, smoking, and number of level fused, did not have anything to correlate in their study. And most of the time, they found that in their study, what they found was most of the time it was a single level, as I had in my case as well. Yet another nice article that I came across was this study by Yuan. This was also a retrospective analysis, and it involved around 700 patients. And they also reported almost similar incidence of around 4.7%. They did not describe any time of onset in their study. And in their study also, the incidence was seen more cranial to the few segments rather than caudal. And in addition to the BMI and pre-op adjacent disc degeneration, what they found was that the bone mineral density, low bone mineral density, predisposed to more amount of adjacent segment degeneration. So majority of these studies, these two studies, they never mentioned radiofrequency of facet joints as a modality of treatment. Rather, they focused more on the surgical interventions. Like some of the cases in their studies, they even had a redo TLIF for their patients. So the problem in our case was if we are choosing radiofrequency as one of the modalities for addressing the facet joint pain, in that case, what can happen is the localization of the landmarks may be difficult because of the presence of hardware, and more so the anatomy may be distorted after the surgery. So the conventional method will not be a viable option in such patients. That is why we need an alternative technique to denervate the facet joints. So what was the rationale behind whatever we did in our patient? So the first rationale that came from the popular technique of denervating the sacroiliac joints for chronic sacroiliitis, that is the palisading RF technique, which was described by Rajai et al. Second rationale behind this was there are some anecdotal case reports about the intra-articular application of radiofrequency, which was described for osteoarthritis knee. Now, this technique had been described for with pulse radiofrequency. Still, it showed a lot of improvement in the patient. In our case, we had done a conventional radiofrequency, so the rationale of ablating the free nerve endings and the encapsulated nerve endings inside the joint was more in our case. So as I was telling, so there are different pain generators described for the facet arthropathy. So the pain generators can be located both inside the joint as well as in the capsule. So you can have the free as well as encapsulated nerve endings inside the facet joints, and you can have the nerve endings and the nociceptors on the facet capsules as well. So based upon my rationale for doing this procedure was based upon these three rationale, these three reasons, and I purposefully used a 10 millimeter active tip so that a part of the active tip remains inside the joint and part of it remains embedded in the capsule to denervate the joints properly. This technique, what I observed had four distinct advantages over the conventional technique. And what I noticed was the procedure time was pretty quicker because in this case, the joint lines were very easily visible. So I just had to put in my needle, three needles inside the joint. And uh, second reason was that though I did a sensory motor stimulus, the needle tip, uh, the active part of the needle tip is far from the intervertebral joint, so there is hardly any risk involved. Uh, that means I am not much, bothered about causing injury to the ventral ramus. Third, if I choose to use a cooled RF, that would produce even wider lesion. Plus, the procedure time would reduce a lot. So, cooled RF with this procedure that might give you better results and would hold better promise than using a conventional technique. And the fourth was that if I am not lesioning the medial branches, there is also no chance of weakness of the multifidus muscle. So these were the four advantages that I noticed while I was doing this procedure. So, and as I had shown you the results speak for that. After having done these two cases, I felt a lot more comfortable and confident about doing a few more cases using the same technique, even electively, even those patients who haven't had instrumentations. And I had got good relief lasting at least for more than 1 year in these patients. But a single study, as in my experience, would not be enough to call it an evidence. So what I would urge is that we need more amount of multicentric prospective studies so as to include this technique as a part of routine procedures. And I had submitted this procedure, this case study for consideration to the Indian Journal of Pain, and they have been nice to accept it for publication. So that was published in June 2025. That's all from my side. I hope you enjoyed listening to my talk.
Thank you, Dr. Ashish. That's actually a very unique way of doing like transfacetal. Anyone else has heard of this technique? Ashu sir, Dr. Sunny, Ashok Kumar sir has also joined. Dr. Divesh?
I think few cases of there, I think, and joint directly joined RF. I think something is reported like that. And also one paper I think I have seen that was they have used the that Diros needle, basically tined one, and placing it away from the medial branch, basically the more distal towards the joint. That means not exactly over the medial branch. That means again the advantage of, as Dr. Ashish said, to not to cut the multifidus out of the innervations, so that the more distally or towards the joint if you go. But I think still there is no any as such RCT, or I think I don't have not seen any. But I think facet joint RF or something has been tried before, to my understanding. But I think yes, uh, but this is something unique in that way.
But
So
knee joint RF,
actually,
they said there was, I mean, they use viscosupplementation also. So, I mean, I don't know how they would just
Yeah, Visco.
for
so
knee joint.
in their case, what they did was they put in a needle and they did a pulse radio frequency. And after the end of pulse radio frequency, they did a visco supplementation. So actually, whether the results were because of
Which
the pulse
work
radio frequency or visco
exactly?
supplementation is not very clear.
Yeah.
Mhm.
And it was a case series, so I don't think any randomized trial has been done on that.
Okay, but obviously one thing that I was here, because as you said in the first case you did 3 needle, and the
Yes,
second you did 2 needle,
two
isn't it?
needles. Yes, yes.
So when you are stimulating, basically when you're doing the sensory stimulation, then uh, normally in the medial branch that you saw that yes, you are having a multifidus contraction also. But
Mhm.
in this case, obviously you are not.
So this is
Only thing.
here I was relying upon reproduction of the same symptom. If the patient says कि हाँ मेरे को ये वही वाला दर्द हो रहा है,
See, with the
I'm
motor
having the
as well,
same pain as I
what were you seeing with the motor? You're ruling out the ventral root.
see.
Yeah.
Initially I did out of impulse. I just for the sake of safety that I did a sensory and I did a motor.
Hmm.
Then later on when I kept doing the cases, I realized that neither sensory nor motor is important here. You
Hmm.
can simply put in the needle, and because it is there in the facet joint, it is quite very far away from the ventral roots.
That
So it,
your needle is not inside the joint. Am I
it is
right?
there inside the joint.
Inside the
It
joint.
is inside the joint, and I am using a 10 millimeter active tip. So part of it is inside the joint, and part of it is uh, on the capsule.
Okay.
So it is addressing both the free nerve and the
Mhm.
encapsulated nerve endings inside the joint, as well as the nociceptors on
Actually,
the facet joint
same thing.
capsule.
Same thing as you said. No, SI joint. We tried. Well, I think one study we're about to complete also that for the SI joint, but SI joint is very big one. So we did a putting
So
the cold RF
yeah.
needle inside the joint and doing the PRF.
So
But the
here
results are not so.
actually, yeah, exactly. I'm what I want to point out here is when you put the needle inside the joint in SI, uh, maybe the capsules are denervated, but the free nerve endings inside the joint are not. That can be one reason why
Yeah, that's a
it
big.
might.
This is very difficult to actually. The area is also big. In this
Yes,
case, in your case, it is a small area,
small
and
area, yes.
that is advantage. SI joint,
Yeah,
it may not fit into both in
yeah.
that way.
And secondly, what I believe is when you are doing a pulsed radio frequency, it is just a sort of neuromodulation. So, and time and again, I have showed in my other cases also, like even for glossopharyngeal, I was telling the other day that the pulse radio frequency gives you a result of approximately 2 weeks only. I have never seen it more than 2 weeks.
So
So,
PRF is actually, I must say, it is unpredictable.
yeah, yeah.
You don't know which
No, no,
case you are getting.
actually, to be very honest with you, it is very much predictable that the pain relief won't last beyond 2 weeks.
In that way, obviously, in that. Nee,
Yeah.
but I think one thing that also again I think, see, anyway the joint is getting innervation of the medial branch, isn't it?
Mhm.
And the branches that is traveling through the supraarticular process that is going to the joint. So
Yes.
do you think that if you denervate that distal part, that means that the distal branches of the middle branch
Mhm.
or the over the border of the your supraarticular process, that is
Yes.
basically
Mhm.
in spite of the joint itself,
Yes.
do you think that, or you can try that, that is also going to work? Because if you are doing the distal branches of the middle branch
Definitely,
denervation.
definitely. That's why I said that if you use cooled RF, no, then that could be because see the cooled RF, the size of the needle is such that it might not get inside the
It
facet
won't go
joint,
into the joint.
No,
It's
no,
right?
no,
just too
But
big.
exactly.
then,
Even the
but then
SI
if
joint is
you're
difficult. We are putting, matlab, we hai na, even entering to the SI joint is difficult. So
yes,
in
yes.
this joint, obviously, it is
So
really difficult.
yeah, so if you just place it over the, just try to embed the needle over the facet joint and do a cooled RF, that will give you superior results.
But 18 gauge needle you were able to put in, right?
Yes, yes. In this case, I was able
But
to put in
chances
the
of a
18 gauge
young
needle.
patient might be chances of capsular damage or something also possible because cool RF needle is big needle and that also it might.
Yeah,
Uh,
so we are not embedding into the joint. Yes, definitely, because we are over the capsule, it might. And moreover, we are doing with a 60 degree centigrade in cold RF. So, and another thing, what I was telling the other day was when we are doing facet joints, many number of times I have used, I have put PRP also.
yeah,
So
PRP. Okay.
that can help regenerative process as well.
The PRP because now another study has come also in cervical joint that is a facet joint PRP. I
Hmm.
think this in RAPM.
Hmm.
So their results are not promising, but still the studies are there. That means it is giving result. Matlab, it's same corticosteroid is giving you if it is giving around 9 months and the PRP also giving 9 months, it is better to use PRP rather
Better to
than
use
corticosteroid.
RPRP, yes.
That
But
is
I
not
still
included.
believe that if you use RF for tiding over the acute pain and PRP for the longer, for to last longer, that would be a better option than using PRP alone,
Well, along with the RF you're selling.
along with the RF, yes.
Hmm. Nee, but obviously, that's the reason actually the prolotherapy and all along with that we are doing so that it will take care of the periarticular ligaments and the other soft tissue or those part
Yes.
rather than only the nerve.
So in both of these patients, I had not done PRP just to uh,
Hmm.
But I
point
mean,
as
for
a
how
disclaimer,
long?
yes.
The case you did was in 2024. So, I mean, did you follow him up like
So
hard?
the first case was in April 2023. The second was in June 2023.
Mm,
And the follow-up was for 1 year.
mm,
And during this time period, actually, I was the one who called them up at 6 months and 12 months. They did
mhm,
not.
mhm,
Okay, and both the times I had to ask them over the phone whether
mm,
they are having, and because they knew what is NRS,
mm.
so they could tell me the scores.
So till
But
1 year
after
at
that,
least, they had good pain relief. So
yes,
that is
yes,
equivalent
yes,
to
yes,
the otherwise RF we
yes,
get from the
yes,
medial branch.
yes.
That is
And
also
they
one of
have
the
my direct
reasons.
numbers. They can always call me, but they haven't till now. So I'm just assuming that they must be having
I mean,
good pain
the
relief with
case
that.
you
Yeah.
presented first, like the one you published, was in a lot of pain. So I'm
Yeah,
sure.
NRS of 9 by 10, and if he gets pain relief, I'm very sure that he's going to call me up if he has a recurrence of pain.
Mm. So if I mean this is like one of the two go methods, at least when the medial
Yeah, at
branch
least
is not
when, yeah,
visible, yeah,
yeah. If the
not protruding.
memelo-accessory groove is not visible, you should try this method.
That's a very good case of having getting the idea of alternative technique because
Correct.
many times we face this difficulty.
True.
Okay, great. Dr. Divyansh, are you ready with
Thank you.
your case?
Yes, ma'am. Good evening.
Okay, great.
Is my screen available? Visible?
Not yet.
Not yet.
I've made you co-host, so you should be able to share.
Yes, ma'am. Is it coming now?
Not yet.
On my screen, it is showing that I'm able to share.
Dr. Dhruv, are you able to see his screen or from your end, or am I the only one who's not seeing his screen?
Not
Ma'am,
seeing
I'm also not able to see, ma'am.
Hmm.
एक बार फिर
it.
से I'm doing it again. Just a second.
Okay.
Good evening, everyone. So I'm presenting a case of complex regional pain syndrome, which was followed after a breast surgery for fibroadenoma. So this was an international patient who was 42-year-old female, and she underwent a lumpectomy for a benign fibroadenoma in the left breast, a common procedure. But she developed severe pain 6 weeks post-surgery, which was quite disproportionate, and it was with swelling and skin changes over the breast. The patient reported to our hospital for another surgery because in her country she was told that she had some findings on the mammography. But after detailed investigations over our hospital, there was no mass or no swelling inside the breast was found, and then the patient was referred to me. So usually fibroadenoma excision rarely triggers CRPS, but post-surgical trauma can initiate sympathetic dysfunction. The clinical presentation, patient reported severe burning pain with a VAS score of 8 by 10 in left breast radiating to axilla and arm. There was allodynia to light touch and edema starting 6 weeks post-op. Patient characteristically was not able to sit with her arm lying by her side. She was sitting with her arm raised. So her complaint was that I am not able to put my arm also on my chest. On physical exam, there was hypothermic skin, the temperature asymmetry was present. There were some color changes, hyperhidrosis, and limited shoulder range of movement. The symptoms had already persisted for greater than 3 months, and it was disproportionate to the inciting surgery. So, in the
Divyansh,
Budapest,
the slide is not moving.
अच्छा, uh,
सेकंड स्लाइड ही दिख रहा है हम लोगों को, मुझे तो खैर।
okay. अभी दिख रहा है सर?
Yes, yes.
यस
Third, you're on slide. Yeah, Abhi, you're able to.
Budapest criteria?
Yes.
अब दिख रहा है।
ठीक है. So, according to the Budapest criteria, she met almost all the criteria. There was continuing pain, which was disproportionate. The patient had sensory findings. There was vasomotor changes, pseudomotor changes, and motor involvement. And there was no other diagnosis which was explaining the signs and symptoms. Still, the differential that could have been made in this case were post-mastectomy lumpectomy pain syndrome, infection and hematoma, neuropathic pain from nerve injury, and phantom breast pain. So I started the patient on a pharmacotherapy treatment. I followed the WHO ladder for the analgesics. There was no opioid used. I started her on gabapentin 300 milligram BD dose. Then also I added amitriptyline 10 milligram HS. I also added duloxetine up to 30 milligram per day. I also added medrol 4 milligram BD and kept IV ketamine if it was refractory, but it was not used. So after a week of pharmacotherapy, the patient had significant reduction in VAS scores. The patient came happy with a VAS score of 3 by 10. And because it was an international patient, I was requested if any further intervention I can do to help the patient because they had to fly back. So, in this case, the interventions that could have been done were the stellate ganglion block or the thoracic sympathetic chain block. And in refractory cases, we could have planned for spinal cord stimulation. In this case, I went ahead with thoracic sympathetic chain block. So, patient was explained about the procedure, including the risks and the benefits. Basic laboratory tests were done for CBC, PTINR, and viral markers. IV line was placed, and standard ASA guidelines were used for conscious sedation. The thoracic sympathetic chain runs mostly in the half posterior part of the vertebral body, the posterior 1/3 and the anterior 2/3. The target for thoracic sympathetic block for me was the T2, T3 vertebral body. So this was my needle placement in the AP and lateral view. I was able to achieve the replication of same symptoms on sensory stimulation as well. After a good diagnostic block, I planned the patient for a radiofrequency ablation of thoracic sympathetic chain. And patient after the procedure had a good pain relief, and I have been on following up the patient for last 3 months. The patient still has a very good pain relief. About the VAS score is on 2 by 10. So I just wanted to add one addition to the guidelines of diagnosing CRPS, as the American Society of Interventional Pain Physicians have added new diagnostic guidance for chronic complex regional pain syndrome, which is defined as CRPS, which has been going on for more than 12 months. Because there is a lots of discrepancy in how to come to a diagnosis of CRPS. So what all points they have mentioned in their paper is the general criteria to establish a diagnosis of chronic CRPS. All three of the following must be met. First, the patient has met the Budapest criteria for CRPS for the first 12 months. The chronic CRPS remains a diagnosis of exclusion, and chronic CRPS type 1 and 2 are regional conditions and must be differentiated from primary or secondary nociplastic conditions causing generalized pain. History-based criteria, at least 3 of the 5 historical features must be present. Sensory, reports of allodynia, hyperesthesia or hyperpathia. Vasomotor, reports of temperature, asymmetry and or skin color changes. Pseudomotor edema, reports of asymmetric edema or sweating. Motor trophic, reports of decreased range of motion, motor dysfunction and or trophic changes, example in hair, nail and skin. Contralateral overutilization, increased use of the unaffected limb due to pain or dysfunction in the affected limb. So 3 out of these 5 are at least needed. On physical examination, there are more criteria. Criteria A, general physical exam findings, at least 2 of the 3 must be present. Avoidance of usage of the affected limb with contralateral dominance or overuse. Evidence of allodynia, hyperesthesia, and hyperpathia or reduced tactile equity. Example, decreased 2-point discrimination in the affected limb compared to the unaffected side. Asymmetric limb girth, accounting for factors such as occupation, activity level, or hand dominance. Then superficial trophic changes, again, at least 2 of the 3 must be present. Superficial trophic changes, example, skin thinning or breakdown, hair pattern differences, nail dystrophy. Vasomotor findings, which are visible temperature asymmetry and or skin color changes, and pseudomotor and edema findings. Then musculoskeletal or trophic changes, all 3 criteria must be present. Decreased range of motion, contractures or fixed postures, motor dysfunction, including weakness, tremor or dystonia, musculoskeletal changes, including atrophy, changes in limb girth or joint abnormalities, example, frozen shoulder. In addition to all these clinical criteria, they also added few diagnostic testings, which are supportive criteria. These tests are not required but may support the diagnosis when criteria 1 to 3 are met, which are reduced intraepidermal nerve fiber density on punch biopsy, bone remineralization in the affected limb, example via X-ray, CT or bone density testing, positive response to sympathetic block indicating sympathetically maintained pain. That is my presentation. Thank you.
Thank you, Dr. Divyansh. So you did stellate ganglion block, like ultrasound guided at C6, and then you proceeded the.
No, ma'am. I initially did only, I straight away went for a thoracic T2, T3 sympathetic block with the local anesthetic in my first setting for the diagnostic block,
Okay.
which was CM guided, fluoroscopy guided, the pictures that I shared.
Mm-hmm. And in
And
the
then
second, like next day, you went for sympathectomy or in the same table? Like
3 days I waited for the relief, ma'am. I was looking at the patient response because initially when the patient reported, there was a very big question mark about the reliability of the symptoms. International patient, there was lots of she
language
was
barrier.
yes, language barrier. Also, they were very hinged on to get the surgery done. So they actually came up with the complaint that we want the breast to be removed. So when they got the answers from the surgeons that no surgery is required, they were very disappointed. So I was also looking for the fibromyalgia component, but when the examination showed clear, stark signs of CRPS, and then I moved ahead with the pharmacotherapy. But again, pharmacotherapy could have been giving treatment release in the fibromyalgia part as well. So then I went for the thoracic sympathetic diagnostic block, but she had great relief after that.
So, did your surgeons? I think she must have been referred to you by a surgeon, right?
Yes, sir. Yes, sir.
So, did they realize that it was a CRPS,
No,
or
sir.
you? Yes. So
They
that is
did
the
not.
problem here. because most of the surgeons are still not aware that such a possibility can
The only good
be there.
thing was that they were not wanting to operate her because
Yeah, because they didn't find anything operable
yes,
in that.
which was the
Yes.
good thing on their part. They did
Yeah.
not, they was like, please look into it. What is it? We don't know, but look
Mm.
into it.
Yes.
Yeah, I have a comment, Dr. Anchal.
Please, sir, please.
Yeah. First of all, very well managed, Dr. Divyansh. Congratulations to you.
Thank you,
Yeah,
sir.
and only thing which I would like to ask you, how much period you have followed up this patient? You were able to follow up, or the patient you lost contact with the
No,
patient?
sir. I did this procedure 3 months back, and I'm still in touch with the coordinator,
Right.
the international coordinator, and
Right.
the patient has a VAS score of 3/10 right now, and I have stopped the steroids 2 months back.
Right.
Patient is still on gabapentin and amitriptyline.
Right. So only thing which I would like to say is, at times you were successful and you could hit the target. At times there can be anatomical variation with the second thoracic sympathetic ganglion. A beautiful study which was, I don't know which particular journal was it, but they had studied 20 cadavers, and they found in around 90 to 92%, yes, it was located at that particular level, the disc between second and third thoracic ganglion. uh, uh, but in about 5%, they found there was a fusion of the first and second thoracic ganglion, and in another 5%, they found a fusion of the stellate first and the second thoracic ganglion. So we must keep it in mind, that those kind of variations we can always come across. Right. That is one aspect which I thought. And of course, everyone knows the connections do exist between the first thoracic, the ventral ramus, and the second intercostal nerve through your nerve of Kuntz. That's one. No, I would just like to add my personal experience with can I take 2 minutes, Dr. Anchal?
Yes, please,
Yeah.
sir. Please.
We actually got a referral, and that was CRPS following mastalgia. I mean, the mastectomy for mastalgia, I would rather say. And, mastalgia is one condition where, usually mastectomy is never done. And, but somehow, they attempted because patient had intractable pain for whatever reason surgeons decided. Now, it was almost 4 weeks following the surgery that I got this referral. And in this particular case, patient had typical symptoms like, I think Dr. Divyansh said 6 weeks. This was just 4 weeks following the surgery. And this is where I found that something, we tried, of course, the stellate ganglion block and, repeated stellate ganglion block didn't help. It was only a temporary pain relief which was obtained following that. And of course, I had in my mind either the radio frequency or plan for continuous thoracic sympathetic ganglion infusion. Now, this was something which was which I had never done. I had never done before. Targeting your needle, using 18 gauge epidural needle and targeting it with that 10 to 15 degree, of course, oblique, and you're hitting the lateral surface of the third thoracic vertebra and reaching the posterior 1/3, that particular aspect, and leaving 20 gauge epidural catheter. Now, we gave this continuous infusion of ropivacaine 0.2%, ropivacaine for almost 6 to 7 days. And I can tell you it really helped. But yes, that particular admission for 6 to 7 days was too much for the patient. Obviously, those kind of limitations are there. But then we did follow up for, I would rather say, 4 or 5 months. Only we could do that much. And patient had significant pain relief, the NRS pain coming down from that particular 9/10 to around 1.5 or 2/10. So I was just trying to add upon that. Yes, radio frequency is wonderful option for that. But then you always have another option if at all it is possible. If at all it is possible, I think one can always go ahead with this particular one. Though there are people, if you scan the journals, you'll find people have tried even neurolytic blocks using ethanol or absolute ethanol 95%. So that's all I thought I will add upon this thing.
No, thank you, sir. Thank you.
And congratulations for wonderful presentation. Yeah.
Yeah, thank you.
Sir, if I can ask Ashok sir.
Yeah, please.
Sir, why didn't you think of putting in a